Hello, my name is Henry Martinez, and I am a family nurse practitioner specializing in orthopedic care in San Marcos, Texas. My scholarly project was on the comparison of rates of superficial surgical site infection and revision arthroplasty among non-obese, obese, and morbidly obese cohorts after total knee arthroplasty. My faculty advisor was Dr. Jane Champion, and my DNP mentor was Dr. Christopher Jimenez. Obesity affects approximately 35% of the adult population in America. Obesity is body mass index of greater or equal to 30 kilograms over meter squared. Morbid obesity is defined as BMI greater or equal to 40 kilograms over meter squared. Obesity is a known risk factor for development of osteoarthritis. Osteoarthritis is a chronic degenerative joint disease presenting with pain, joint stiffness, and a progressive loss of function with an impact on quality of life, disability, drug consumption, and mortality. Osteoarthritis numbers are expected to continue to rise due to the aging population and the obesity epidemic. Obesity affects the knee through increased joint loading, changes in body composition which lead to a constant state of inflammation, and behavioral factors such as decreased activities, which eventually lead to decrease in protective muscle strength. Here we can see on the left side of the image the joint space narrowing at the medial or inner portion of the right knee. Additionally, you can see on the tibia an area that appears to be whiter just below the joint line. That is sclerosis, which is hardening of the bone below the cartilage. And also in the inner aspect of the femur, you see a large osteophyte, which is also indicative of osteoarthritis of the knee. I would grade this as a Kellgren and Lawrence grade 3 on a scale of 1 to 4, with 4 being the worst osteoarthritis. The American Academy of Orthopedic Surgeons states that selecting a candidate for surgical intervention is one of the most complex decisions in surgical practice because you need to balance the degree of pathology and surgical risk versus benefit. Most literature delineates morbid obesity to be the threshold where there is increased risk for superficial surgical site infection and deep periprosthetic joint infection requiring revision arthroplasty. The American Association of Hip and Knee Surgeons recommends that patients with symptomatic osteoarthritis of the knee who are overweight should be encouraged to lose weight, a minimum of 5% of body weight, and maintain their weight through dietary modification and exercise. This creates instances where patients must decide whether to lose weight and achieve a BMI of less than 40 to undergo arthroplasty, to find another surgeon that's willing to perform the surgery at their current weight, or be left with pain and disability. The aim of this project is to determine whether obese and morbidly obese patients had increased rates of superficial surgical site infection and revision arthroplasty compared to non-obese patients after total knee arthroplasty. This was a retrospective chart review via a convenient sample of the electronic health record from a specialty clinic in Central Texas. The inclusion criteria included cases with end-stage knee osteoarthritis undergoing primary total knee arthroplasty between the ages of 40 and 99, between 19 kilograms and 49.9 kilograms over meter squared. The exclusion criteria were BMI of less than 19 and greater than 49.9, or a history of total knee arthroplasty. And this is a good picture of a good example of a superficial surgical site infection. Data analysis. Demographic data were analyzed for descriptive statistics, cross-tabulations, and chi-square tests are performed for categorical variables. Superficial surgical site infection is defined by the CDC as infection within 30 days that involves skin or subcutaneous tissue with any of the following: purulent drainage, positive culture, or erythema. Revision arthroplasty is surgery to replace one or more components of total knee arthroplasty. It occurs most often for polyethylene wear, aseptic loosening, instability, or infection. Data were analyzed using IBM's SPSF software. This is a breakdown of the racial demographics. On the left, you can see 95% of participants were white, 4% African American, and 1% Asian. And ethnicity, 71% not Hispanic or Latino, and the remaining 29% were Hispanic or Latino. Sex, 57% of the 178 participants were female, and then a breakdown of the cohorts on the right shows morbidly obese patients were 30 participants, non-obese were 55 participants, and 93 obese participants. Ages ranged from 45 to 92, with a mean age of 67.49 and a standard deviation of 10.405. BMI ranged from 19.4 to 46.7, with a mean of 32.71. The obese cohort had the highest rates of superficial surgical site infection at 8.6 and revision arthroplasty at 2.1%. The non-obese cohort had a superficial surgical site infection rate of 7.2%, and the morbidly obese cohort had the lowest rate of superficial surgical site infection at 3.3%. Non-obese males had the highest rate of superficial surgical site infection at 16%. Non-obese males, obese males, and obese females comprised 92.3% of total superficial surgical site infections, and males had twice the rate of SSSI at 10.4% compared to females at 4.9%. So obese women had the higher rates of superficial surgical site infection compared to non-obese and morbidly obese women, 8.6 versus 0 and 0% respectively, with power of 0.057. Conversely, non-obese males had higher rates of superficial surgical site infection than obese and morbidly obese males at 8.6 and 5.9% respectively. Both revision arthroplasties began as superficial surgical site infections, as would be expected because the infections typically start as superficial infections, and then as they progress, get the possibility of getting actually into the joint to cause the deep periprosthetic infection that would require revision surgery. Here's a breakdown of cases by cohort. The non-obese cohort had 4 superficial surgical site infections and 0 revisions. Obese had 8 SSSIs and both revisions, and the morbidly obese cohort only had 1 SSSI and no revisions. In conclusion, as obesity continues to proliferate, there will be a corresponding increase of total knee arthroplasty in the obese population. These findings show that the obese cohort and not the morbidly obese cohort, as in previous studies, are at greater risk for superficial surgical site infection and revision arthroplasty after total knee arthroplasty. Here you get a visual of the total knee arthroplasty x-ray after implantation. You can see that fuzziness below the tibial implants on the lower portion. That is bone cement. Limitations. This was a retrospective chart review, so we were dealing with retrospective data. It was a non-randomized, single-site, convenient sample, which could allow for bias. There's a small sample size and unequal cohort sizes. Implications for practice. It's not imperative that morbidly obese patients lose weight to fall below the 40 kilogram over meter squared BMI threshold prior to total knee arthroplasty, and providers should be comfortable recommending TKA for their morbidly obese patients. These are my references. Thank you to Dr. Champion, Dr. Jimenez, and to my family.